Hi, and welcome to the show where we share the stories of the many who intersect with our healthcare system but are rarely heard from. My name is Kevin Poe, founder and editor of KevinMD. Rate and review the show at kevinmd.com/rate. Subscribe at kevinmd.com/podcast. Today in the show, we have Layla Parast. She's a statistician, and her KevinMD article is titled, "It's Time to Address Pain Despite the Opioid Crisis." Layla, welcome to the show.
Thank you. Thank you for having me.
So we'll get into the article in a little bit, but first off, briefly share your story and journey to where you are today.
Sure. I am an associate professor in the Department of Statistics and Data Science at the University of Texas at Austin. Before this, I was a statistician at the RAND Corporation, which is a nonprofit think tank out in California. So I was there for 10 years, loved it, but needed it. And before that, I was in school. So I have my PhD in biostatistics from Harvard and a master's in statistics from Stanford. So definitely very statistics trained.
So regarding that intersection between healthcare, data, and statistics, a lot of the lay public, a lot of physicians for that matter, sometimes we have trouble interpreting the data. So tell us about that intersection between healthcare and statistics and areas where you think that we can improve when it comes to interpreting healthcare statistics.
So at RAND, I learned a lot about that myself. My training in graduate school was very much methods focused and not presenting or communicating with non-statisticians. And at RAND, I had the opportunity to communicate with all kinds of people, physicians and senior researchers who are very smart and very good at what they do, but they are not experts in statistics, just like I am not an expert in medicine. So being able to explain the results and concepts to them, being able to explain results of very complicated analyses to people in government that are going to make very important decisions based on what you say. And if they don't understand what you're saying, it doesn't really matter how great your analyses are. So that was very humbling for me and a long journey to learn how to communicate with them and to learn that, if someone doesn't understand what you're saying, you need to try a different way. You can't just keep repeating it in the same way. What's the standard deviation? Things like that. That seem so simple to me, but they're not. And communicating with the public, we certainly had to write a lot of communication that was meant for patients, providers, other stakeholders, and again, had to take very complicated statistical concepts and make them transparent and understandable.
Now, for those of us who don't have degrees in statistics, it could be patients, it could be clinicians. If we want to get better at interpreting studies and just get better at statistics in general, what are some easy ways that we can do that?
I feel like there are so many books now that aim to do exactly that. Nonfiction books that are trying to take these very complex statistical concepts and explain them to regular people who are very smart in their own right. I have found those very helpful myself. So I recommend those. Honestly, this maybe sounds very silly, but YouTube has so many great videos. My goodness. This semester, I am teaching freshmen and I'm teaching them Introduction to Data Science, which has been very fun. But there were some things that were in the curriculum that I didn't know how to do, like web scraping. I've never scraped data from the web. So I had to learn how to do it. And I learned by watching YouTube videos, and they showed me how to go through the R code, how to find the HTML tags. It was pretty incredible. It's incredible what's out there. And I just taught that to them yesterday and told them myself that, let me be honest, I learned this on YouTube. So there's so many great resources. Professors make a lot of videos online that honestly, their YouTube videos are better than their in-person classes because they have to make them short and clear and punchy, and it gives people an incentive to make great content.
Let me ask one other statistics related question, because honestly, we don't have very many statisticians on the show. So I wanted to take advantage of this, and then we'll get to your article. Now, if you're reading some type of statistics in the lay press, what are some red flags that we should look out for just to give us a sense of, hey, maybe we shouldn't quite trust this interpretation? Any red flags that we should look out for whenever we read about statistics on the internet, for instance?
My biggest red flag is when you read anything that is talking about an intervention or comparing two groups based on some characteristic, and then they conclude that whatever analysis they did implies something causal. One that I've had experience with is we took households that have pets, and then we took households that don't have pets, and we looked at the kids, and we looked at the physical health and the emotional health of those kids. The kids in the households with pets were healthier physically and emotionally than those without pets. You will find so many articles that will take a study like that and be like, oh, pets improve a child's physical and emotional health. And that feels right. I grew up with a dog. That must be true. But we have done that analysis using this huge household survey in California. And it was true that when you compare those two types of households, that's what you see. Households with pets are also much more likely to be white and have parents that are working full time, have higher income, all kinds of other characteristics that are also associated with better physical and emotional health, good or bad. And once you account for those differences, there is no effect of pets on children's physical and emotional health. So at least in our analysis. So that is my biggest thing when I read something and it says, we compared these two groups, and because we saw this difference, that means you should take vitamin E every day. That means you should drink coffee. That means you should stop drinking coffee. Did you account for all of the other things that are different between the two groups? I see that over and over. And I think that it's very convincing if you don't know to look for that.
All right, let's talk about your KevinMD article now.
Okay.
I'm going to change topics here. It's titled, "It's Time to Address Pain Despite the Opioid Crisis." Now, for those who didn't get a chance to read your article, just walk my audience through it, share the story why you decided to write it.
Sure. So I am a fellow of the Public Voices Op-Ed Project. It's a year-long fellowship geared towards women and minorities to get our voices out. And we were encouraged to think about something that we felt we were an expert in and also felt very passionate about. And this topic of pain immediately came to mind for me. So when I was at RAND, I worked for 10 years on several projects related to patient experience surveys. You go to the hospital, you're discharged, you come home, you're very likely going to get this HCAP survey, a survey about your experience in the hospital. And to be honest, when I first started working on these projects, I thought, who cares if your doctor's nice to you? Does that matter? Doesn't it just matter if they make sure you don't die and cure you and things like that? So I definitely was not a believer in the beginning, but I completely changed over my 10 years working there. Numerous studies have shown that patient experience does matter. Patients are more likely to fill their prescriptions, to follow their follow-up care guidelines, to come back to the doctor when they're supposed to, if their doctor was nice to them and listened to them and treated them with respect. Anecdotally, I see it in my dad, I see it in my friends. You don't want to go to a doctor that isn't pleasant. And I know there's this argument that hospitals are not hotel rooms. It's not supposed to be a nice experience to be in the hospital. And that's true. No, healthcare is not fun. No one looks forward to it, but that doesn't mean you can't expect to be listened to and treated with respect. So patient experience in general has been something that I worked on a lot. I was the statistician on several projects, and then I led a very large project funded by the Centers for Medicare and Medicaid Services to develop and test the patient experience survey in the emergency department setting. So there was not a CMS implemented patient experience survey in the ED setting. And so we were tasked with developing it and testing it. And a huge part of that survey was pain questions. Sure. Pain is very important to patients, especially in the emergency room. People go to the emergency room if they think they're going to die, if they're scared, or if they're in pain and have nowhere else to go. So we spent a lot of time working with focus groups, doing cognitive testing in English and in Spanish of pain questions. When the opioid crisis started, it's ongoing, not surprisingly, there was a lot of public discussion around whether having questions around pain and prescriptions for pain on a survey incentivizes doctors to overprescribe opioids in particular. Results from these kinds of surveys are typically publicly reported, and they inform payment in some settings. So it was very political, and I worked very hard with my team and with CMS to test new pain questions that were not about prescriptions for pain, but were instead about communication about pain. So asking the patient, did your doctor talk with you about pain? Did they ask you about how much pain you were in? Did they talk with you about managing your pain when you got home? So nothing about, did you get a prescription? And we changed the questions on the survey, but the political pressure on CMS, and I do not speak for CMS at all, don't work for CMS, but the political pressure on them to completely remove those questions from the survey was immense. And so they did remove them from.
Now, who was pressuring them to remove those questions?
So physician groups, Congress, those are the big ones that we saw documentation of, and I linked to it in my article, very much physician groups. So yeah, the ultimate pressure came from Congress.
And was it because of the perception that these questions implicitly pressure doctors to prescribe more opioids?
Yes. There have been numerous studies analyzing the association between responses to these questions and opioid prescribing and not finding a link. So there was no evidence that there was a link. It was this pressure.
Okay. So where do we stand now?
So the questions are not on the survey at all. Any of the surveys, they were completely taken off, and that's where we are now. And I'm not at RAND, so I don't work on that project anymore, but it just seems astounding to me to have surveys about someone's experience in the hospital, whether inpatient or ED, and not talk about pain. Pain is a huge component of your experience in the hospital. That doesn't mean it needs to be publicly reported. It doesn't mean you pay providers based on the responses to those questions, but I think we should be asking those questions. I think we should measure it. How can we look at things like racial disparities, gender disparities in pain management if we don't even ask those questions? It's not enough to just look at prescriptions, the EHR looking at prescriptions to look at disparities. That's not what we're talking about. So it's a huge loss to me that they were taken off the survey. And that was the message that I wanted to get out there.
So you're proposing an obviously much more nuanced approach to asking pain questions. And you must feel that you have to thread a needle here because this is a heavily politicized issue. So give me some examples of some questions that you would ask patients when in regards to pain.
So the questions that we tested and worked well, and by worked well, I mean, we do cognitive testing of survey items to make sure that patients with different educational levels, language levels can understand the questions similarly and respond similarly. So simple question is one that I mentioned. Did doctors and nurses talk to you about your pain? That's it. And the response options are yes, definitely, yes, somewhat, and no. That's it. Did doctors or nurses, or you can say, did hospital staff talk with you about how to manage your pain when you got home? I don't think those are controversial questions. We did test some questions that were around alternatives to prescriptions. So did hospital staff talk with you about ways you could manage your pain besides prescriptions? And then there was a checklist. Did they talk to you about ice packs, heating pads, acupuncture, stretches, all kinds of different things? Did hospital staff talk with you about potential side effects and risks to any prescriptions for pain that you were prescribed? So that one was really trying to get at if an opioid was prescribed. You can't use the word opioid on a survey. People don't know what that, we know what that is, but the general public does not know what that is. It's very confusing, and you can't use brand names. So trying to get at whether risk of addiction was even discussed with them. Those questions were a little bit harder for people to interpret. So we stayed away from those questions. But those first two I mentioned, I think are benign and still very helpful questions in terms of measuring what's going on around pain in the hospital.
What's your thoughts about these patient experience surveys being linked in many cases to a physician's pay?
Yeah. Oh, it's such a controversial topic. If I was a doctor, I would not like it. That being said, as a professor, the reviews my students give me are linked to my promotion, heavily linked. Even those open-ended questions that they ask them, they're reviewed when you go up for tenure, when you go up for full professor, every year when you're reviewed. That's a little bit scary, right? A random upset student who just wants to maybe get back at you can really impact your career. Hopefully that doesn't happen. In a small way, I know what that feels like. I think it's a very touchy area, right? I, again, am not a doctor, but I assume that doctors became doctors to save lives, to make people healthier, not necessarily to be like a receptionist and to just be nice. You should be able to be a wonderful, successful doctor, even if you're not that nice. I can see that argument. But again, because there have been studies that show that patient experience matters to patients, it's hard to ignore that. Patients are humans. We're not necessarily going to do what you tell us to do if you're not nice about it. So there's this human aspect that is hard to ignore.
We're talking to Layla Parast. She's a statistician. Her KevinMD article is titled, "It's Time to Address Pain Despite the Opioid Crisis." Layla, what are some of your take-home messages they want to leave with the KevinMD audience?
Take-home messages, I would say, would be patient experience matters. And patients are human, treating them as human, understanding that we are flawed and that kindness will make us do the things that we're supposed to do is something that is just true and it's important.
Well, thank you so much for sharing your time and insight. Thanks again for being on the show.
Thank you.